I'm gonna start recording now, we'll share this video. Hopefully that'll work, but we did a test run and hope it'll work. So thanks again for that introduction. I'm gonna talk to you today mostly about one therapy that we're developing, but I wanna bring back the background of the EGFR Exon 20 problem and you know, at least touch on some of the other strategies that are out there right now. So the title of the talk is Anti-Tumor Activity of Tarlozotinib, a hypoxia-activated EGFR TKI, or tyrosine kinase inhibitor, in cancers with EGFR Exon 20 insertions. And that's a picture of our nice campus there in the lower right-hand corner for those of you who can see it. Disclosures are important here. So the drug that I'm going to be talking about, I'm actually one of the co-founders of the company, Rain Therapeutics, so keep that in mind. And I've also served as an advisory board member for Ariad and now Takeda, relating to their 788 compound, also Spectrum Pharmaceuticals and their Poziotinib compound, and AstraZeneca, not necessarily related to osimertinib, but for other things. So I do have those potential conflicts of interest. So I thought I'd start with just a brief overview of what the epidermal growth factor receptor is. I think it's important for how we think about drugging EGFR Exon 20 insertion positive cancers. EGFR, as you can see here, is actually a member of a 4 receptor family: EGFR, HER2, HER3, and HER4. Probably the most widely studied of all of these receptor tyrosine kinases. If you're able to view this, you can see that it's a transmembrane protein, which means that part of the protein sits outside of the cell, and part of the protein sits inside the cell with a connecting transmembrane region. And the whole purpose of these is to sense signals from the outside of the cell. Those signals are called ligands, and an example of a ligand or something that binds to that receptor is called the epidermal growth factor, or amphoregulin, or others. And these are small peptides that bind to these receptors and induce the receptors to dimerize or form pairs so that they can signal. On the right-hand side of the slide, when that ligand binds and you get pairing, you get phosphorylation of a number of sites on the inside of the kinase, and that is the initial step in activation that then leads to downstream signaling. And this is kind of a complex picture, but this generates a large number of kind of signaling nodes in the cell that tell the cancer or a cell to grow, divide, metastasize, etc. And that's basically how almost all receptor tyrosine kinases work. So EGFR is one of many of these. What's important is that normally this is under very tight regulation. So EGFR is only expressed in certain tissues. The ligands are only provided by other cells in certain environments. And that's what keeps normal cells under control and from growing undivided without any hindrance. There are many ways to inhibit a receptor tyrosine kinase. I've highlighted kind of 2 of the main methods that we use to do this. So on the left-hand side, you can see one method is to use an anti-EGFR monoclonal antibody. An example of that is cetuximab. Though the antibodies typically bind to the receptor, although they can also bind to the ligand, such as EGF, and they block either ligand binding, dimerization, or can do other things to stop signaling of the EGFR molecule. What we're going to spend most of our time on today are small molecule inhibitors. So if you look inside the cell, the kinase inhibitor, an example here is erlotinib or Tarceva. Those have to permeate the cell membrane, and they go inside the cell where they can fit into a nice groove. And so if you look on the right-hand side of the slide, this is now a crystal structure rendering of the kinase domain. So that's the part of the molecule that's inside the cell. Normally, that yellow-green pocket is occupied by ATP when it's active. ATP is an energy source that a lot of different proteins in the cell use. And that pocket, however, can be blocked. And so if you look further in the right-hand corner, you see the tarsiva molecule fitting nicely into that yellow-green pocket. It's been blown up. What that does is that displaces ATP and turns off EGFR. So this is the whole premise of how we typically would drug EGFR or other receptor tyrosine kinases. And you can kind of think of this as a lock and key type of scenario where different drugs like tarsiva can fit into different pockets. And tarsiva, although it's not perfect, is mostly specific for EGFR. It doesn't bind to a lot of the other receptor tyrosine kinases. And this is what generates some of the specificity that we see with our drugs, and that they don't inhibit kind of the whole family. So this part is a bit of a history lesson. I think this is important. So EGFR tyrosine kinase inhibitors were developed long before we really understood the biology of EGFR mutations. And so I took this quote directly from one of the early clinical trial publications of Afatinib, otherwise known as Iressa. This is from the introduction, and gives some of the insight into why these drugs were developed and some of the serendipity that we had in developing these. So EGFR is commonly overexpressed in non-small cell lung cancer. So novel agents that inhibit EGFR have been developed as a potential treatment in this disorder. So what you'll notice missing from this sentence and missing from the entire paper that was this Lancet article in 2005 was any mention of EGFR mutation. These drugs were not developed to target EGFR mutations. They were developed because it was known that that protein that I just described was widely seen and expressed on not only lung cancer cells, but also breast, prostate, and colon cancer. And so that's why they developed these drugs. They got very lucky, as I'll show you in a few minutes. So this was actually the results of the trial. This was actually a negative trial. This was all, well, I'm only showing here the adenocarcinoma population, which is where most of the EGFR mutations occur, but this was actually in other non-small cell lung cancer patients as well. These are patients who had previously received chemotherapy and were given either Afatinib or placebo, meaning they were given a pill that had nothing in it. And there was a non-statistically significant difference, meaning that those curves separated a little bit, but this was not deemed a significant separation of the survival curve. So the Afatinib in this trial actually failed. And it failed because it was given to all lung cancer patients without any kind of real understanding of the biology at the time. And ultimately, actually, Iressa was pulled from the US market because of this trial. It recently gained reapproval based on new trials that looked specifically in the right population, but at this time it was actually pulled from the market because it didn't lead to a survival advantage. In this trial, there were some early hints that there might have been some significant benefit in a couple populations, and this is where some of these kind of myths about only never smokers and Asians having this benefit arise from, and that's not really true. But you can see that those, where I've highlighted with the red boxes, the never smoker and Asian population seem to have a more significant benefit than either smokers or patients who were non-Asians. So there's a bit of truth that, and basically what this was doing was enriching for a population of patients that had a certain biology, which was identified here in the next slide. So there were several groups, actually, and this is just one of the groups, that simultaneously identified the reason behind some dramatic responses in patients. And so I've highlighted one on the left. This is a CT scan of a patient with lung cancer. And you can see that the right lung, seen on the left side here, hopefully you can see my pointer, is white and filled mostly with tumor. After only 6 weeks of Afatinib, this patient had a dramatic response and, according to the paper, felt quite a bit better. There were many patients like this that were observed. They went back and sequenced the EGFR gene in all of these patients and noted that the majority of them had a mutation, one of these mutations seen on the far right here in red. And these are either an exon 18, exon 19, or exon 21. And that they then surmised that these patients were the ones who were benefiting from gefitinib. And so this has, of course, revolutionized how we think about lung cancer. We now know, and this is a somewhat outdated chart, but has some of the major oncogene drivers highlighted on the left. We now understand that lung adenocarcinoma is really many different diseases that can be defined by the type of oncogene that they express. And so I've highlighted here on the right-hand side 4 of the known oncogenes, those that have FDA-approved drugs. So EGFR, of course, has erlotinib, gefitinib, afatinib, and osimertinib. ALK has crizotinib, ceritinib, alectinib, and brigatinib. ROS1 has crizotinib, and BRAF V600E has a combination therapy of dabrafenib and trametinib. And so now we understand that you can't really treat all lung cancer patients alike, especially when using targeted therapies. You need to understand the biology behind the cancer. And of course, that has led to the successful development of many inhibitors that I just showed. This is one of the more recent studies looking at osimertinib compared to standard EGFR TKIs. On the left-hand side, you can see the progression-free survival curves, or PFS curves. So osimertinib was superior to standard EGFR TKIs. However, I put a big asterisk on the mutant non-small cell lung cancer because they only enrolled L858R, exon 21, and exon 19 patients. And so obviously building up to the issue surrounding some of the other rarer mutations. And you can see that this drug worked very well in those populations. The patients went a long time before they became resistant. That's basically what PFS means. And the response rate to therapy was fantastic. 80%, as you can see in this waterfall plot, each patient is represented by a bar. And 80% had a dramatic response, meaning greater than 30%. But you can see that almost every patient had some kind of response. There was only, it looks like, 4 patients here that had rapid progression on this drug. So the vast majority of patients with exon 21 or exon 19 mutations benefited from these EGFR inhibitors. And so here I'm going to define the asterisk. The problem is that all EGFR mutations are not the same. And you can see that from the way that they enrolled patients in that trial. We've known about this problem for a long time. They only enrolled exon 19 and exon 21, or specifically L858R, because those are known to be the sensitizing mutations. So they're not only activating, but they're sensitizing. But there are also other mutations, exon 18, exon 20 insertions, and L861Q, that seem to have variable or poor responses to standard EGFR TKIs. And of course, we're going to focus mainly today on the EGFR exon 20 that represents this curly Q, which is called the C-alpha helix of EGFR. So all the exon 20 insertion mutations occur in this one confined region of EGFR, and they are clearly different from others. This is a nice study that was just published by Charlotte Leduc from a large cooperative group where they sequenced, I think, over 10,000 lung cancer patients in France, and they obtained mutation data on a total of 1,800 patients with EGFR mutations. You can see that the vast majority of patients with EGFR mutations have exon 19 or exon 21, mostly L858R. But there's this population here, exon 20. In this study, it was about 6%. It's been anywhere from 4 to 9% in various studies that have these different mutations. And again, there's also these exon 18 mutations that are thought to have a more variable response to EGFR inhibitors. So this starts to highlight some of the problem with treating patients with EGFR exon 20 insertion mutations. If you look at the bottom of the screen, the various colored lines here represent different types of patients: exon 18, exon 19, exon 20, exon 21. So the exon 20s are in pink. If you look at the exon 18, 19, and 21 patients, you see that they have a very nice progression-free survival, meaning time to resistance on EGFR TKIs. You can see that it ranges anywhere from 10 to 12 to 14 months in this study. However, if you look at the pink bar, patients only made it approximately 2.5 months before becoming resistant, which is pretty much the time of the first scan. It's just slightly beyond that. And really not much different than patients with non-mutated EGFR. And that, again, highlights the critical problem with drugging EGFR exon 20 with standard inhibitors. If you look on the right-hand side, this suggests that overall, these patients don't necessarily have a worse prognosis. If you give them chemotherapy, they all do about the same. So they are treatable with standard chemotherapy. And again, you see pretty much the same results, whether you have an exon 19 mutation or an exon 20 mutation, or wild type. So there's nothing different in the overall behavior of these cancers, at least with respect to a more global therapy such as chemotherapy. And again, this is from Dr. Leduc in France. This, I think, goes into a little bit more granular detail. This is a meta-analysis of patients who have atypical EGFR mutations. So atypical is defined as not exon 19 or not L858R. And this was culled from 3 LUX-Lung studies. These are the Afatinib or Boehringer-Ingelheim studies. So LUX-Lung 2, LUX-Lung 3, and LUX-Lung 6. And they divided these patients with atypical EGFR mutations into 3 different groups. We're going to focus on this group 3 here on the right-hand side. Group 1 are kind of atypical non-exon 19 or 21. So these include exon 18 mutations, compound mutations, and others. Group 2 are actually patients who have that resistance mutation up front. So they have a T790M mutation that most often develops after a standard EGFR TKI, but these patients had it at baseline in combination with a number of different mutations. And then group 3 is the exon 20 insertion group. And so again, they were looking for activity of Afatinib, which is thought to be a bit more broad potency EGFR inhibitor in these different subgroups to see if they could identify other indications. Just because I'm not going to give a much more about this, and we'll focus on the exon 20. This actually, the group 1 patients were included in an updated FDA approval that just came out, I think it was this week or late last week. So they do show some activity against some of these more atypical mutations, but as you'll see, not necessarily exon 20. So on the left-hand side, this is again a waterfall plot of Afatinib. I'll have you focus on the dark blue bars. Oops. Dark blue bars, again, are the EGFR exon 20 patients. And here, there were only a handful of patients that had any response to therapy. The red or orange diamonds here actually refer to the right-hand axis, and that's progression-free survival. So meaning how long did they last on therapy before their tumors became resistant. You can see that a lot of the dark blue lines have very short progression-free survival, often in the 1 to 2 to 3 month range. One of the downsides of this study is that they didn't highlight what each of these are, and there are a few exon 20 insertion mutations that may be more responsive to therapy, so we don't know the exact nature of the mutation that this patient or this patient had. Oops, sorry, let's keep bouncing around. On the right-hand side, again, this is looking at the median progression-free survival or time to resistance, and you can see that the group 3 did not do well with Afatinib. Again, almost identical to the prior studies, the median progression-free survival was only 2.7 months if you had an exon 20 insertion. That was far worse than chemotherapy, which was closer to 8.2 months. Okay, so what's the problem? So I'm going to give you information that probably will make most of you smarter than your medical oncologists. This is actually taken from some of my graduate student lectures, but I'm sure that you can all handle this information. And again, it's something that's not, I think, well understood by most. But this is the concept of therapeutic window, meaning that there are doses that you can give that will cause efficacy that won't cause toxicity for some drugs and some tumor types. And this is a general principle that we really need for all therapies, whether it's chemotherapy, targeted therapy, or immunotherapy. You need a dose and a schedule of a drug that can shrink tumors without causing significant side effects for the patient. It's a very simple concept. But I'm going to explain to you why we got lucky. I mentioned that earlier with the EGFR inhibitors. Okay, this is the hard biochemistry part. And I'll go through this quickly and then focus on the kind of seesaws at the bottom. Basically, there was a very fortunate finding that I think, I'm not sure any of us would have anticipated. EGFR activating mutations, here the example is L858R, actually decrease the affinity for ATP. So I remember I told you that the EGFR molecules, their main role is to bind ATP and use that as an energy source to tell the cancer cell to grow. Activating mutations such as L858R decrease the affinity for ATP. That means ATP binds less well. So when this number goes up, that means that's lower binding for ATP. And conversely, EGFR inhibitors bind more tightly, so this number goes down. So ATP affinity is lost, drug affinity is gained in L858R, and that gives this potency. That's basically just putting one number over the other. And you can see that L858R gains this massive potency, right? So you gain this huge competitive advantage. And I'll highlight that down on the seesaw. So wild-type EGFR is more likely to bind ATP, less likely to bind TKI, but L858R completely flips this equation. It's less likely to bind ATP, more likely to bind EGFR TKI. Interestingly, what T790M, so that main resistance mutation that occurs for 2/3 of the patients who get an EGFR TKI, such as erlotinib or gefitinib, what happens with T790M is it actually flips that balance back more towards wild type. So ATP affinity goes up again and drug affinity goes down, and you lose that potency, and that's why the drugs basically stop working in those patients. So what happens with EGFR exon 20? Well, this is the problem that was very nicely defined by Dan Costa's group back in 2013. So again, we've known this for quite a while. If you now look at an EGFR exon 20 insertion mutation, I'm going to highlight this D770 as opposed to the A763. D770 is a known kind of typical EGFR exon 20 mutation that's resistant to therapies. A763 mutations, this FQEA insertion, that's about the only one that's thought to be sensitive to standard EGFR TKIs. What you can see here is that the ATP affinity, here, doesn't go up nearly as, I have a gremlin touching my screen. The ATP affinity doesn't go nearly up as much as it does for L858R, and that the drug binding isn't as high either. So that this molecule, when you look at the, again, the binding affinity of gefitinib versus ATP, it's more similar to wild type than it is to L858R. And again, this exception is, you can see here biochemically, looks more like L858R. It's got this potency of 0.13 versus 0.09, way, way better than wild type EGFR. And so when we look at our models here again, for ATP binding, EGFR exon 20 is much more like wild type EGFR in that it's more likely to bind ATP, less likely to bind drug. And the problem is going to be that whenever you inhibit EGFR exon 20, you're also likely to be inhibiting some wild type EGFR. So we're going to potentially lose that therapeutic window. So this gets us to the problem of an unmet need for EGFR and HER2. We're not going to discuss HER2 too much today. Maybe we'll come back to that at a later point. We are working on that as well in our lab. So again, EGFR mutations are not a monolithic group. We have tarlozotinib, gefitinib, and afatinib, which are now FDA approved for exon 19 and L858R mutations. We even have third-generation inhibitors, which block T790M and are likely to be approved for first-line therapy in EGFR. But what we're lacking are drugs for the exon 20 group in EGFR and also in HER2. So this is the spectrum of mutations that occur in EGFR exon 20. The three most common are highlighted in red. This is important because we've actually made human cell line models that represent each of these three most common models, the insertion ASV, insertion SVD, and the insertion NPH. And again, this insertion FQEA, it's interesting that it's noted at 11%. We actually just went through our data and couldn't find a single one of these in our patients, whereas we've seen many of these other mutations. But this is the one that's thought to be sensitive to existing EGFR inhibitors. But there's a wide variety, and you can see that there's a lot of different mutations that occur, and this is only some of them that are highlighted here. Okay, so what are the strategies to target EGFR exon 20? Well, we could try finding selected TKIs. I told you about the lock and key method. Maybe we can identify EGFR molecules that fit into that but don't cause toxicity. And so there are several examples that are being explored or about to be explored. TAK-788 is currently in phase 1 clinical trials. Poziotinib is currently in phase 2 clinical trials. EGF-816, which is, I think, called nazartinib, a Novartis compound, has a planned clinical trial, as does a higher dose of osimertinib in EGFR exon 20. I'll touch briefly on EGFR monoclonal antibodies, because that seems like a reasonable strategy, and then I'll finish on the strategy that we're now pursuing with Rain Therapeutics, which is this hypoxia-inducible EGFR TKI called tarlozotinib. Okay.
Hey, Bob.
Yeah.
Bob
Yeah.
Hanlon here. Your voice is going in and out a little bit. I don't know if that's me or you, so just want to make you aware of that.
Okay, I'll try and keep speaking up. Hopefully it's not the connection. Okay. All right, so selective EGFR TKIs. Again, we won't discuss all of these, but we'll talk about two of the ones that are furthest along, TAK-788 and Poziotinib. I think Ariad, now actually Takeda, did probably the best job of defining the narrow therapeutic window that needs to be threaded in order to achieve therapeutic express. So you can see it used to be called AP32788, now it's TAK-788. And what they've done here is they've benchmarked inhibition of cells versus a wild type model. So the green bar in each of these drugs is wild type. And what we think is that that is the ceiling. That's the highest dose that we can achieve without causing significant toxicity to patients. And so if you're going to design a drug, it has to have a lower dose than is seen by the screen bar, but a higher dose than the EGFR exon 20 mutations. And so you can see that those are highlighted here for each of the drugs. You can clearly see that tarlozotinib and gefitinib just fly right over that bar, right? When you look at all these EGFR exon 20 insertions, even the FQEA, the dose that you need to inhibit these molecules, these mutant tumors, is well above that for wild type, for tarlozotinib, for gefitinib. It's also true for afatinib. So when you look at NPG and ASV and NPH and SVD, they're all way above wild type. So you can inhibit tumors and cancer cells with these drugs. You just can't get this dose into a patient without causing significant rash and diarrhea, because that's set by the wild type level of inhibition. So when Ariad designed this drug, they thought they could achieve this based on this data. You can see that their blue lines are all below this, but there's still not a ton of space here, right? So you still have to get a dose that is above most of these EGFR exon 20 mutations, but below wild type. So they've, I think, very nicely defined the problem. Same is true for HER2. You have to be above the different HER2 mutants. There are 3 defined here, but below wild type EGFR. And again, you can see why Afatinib and others don't do that. Someone have a question? Okay. So I won't say more about that. That trial, there haven't been any patient results reported yet. That trial is ongoing at our site and 6 other sites across the US, and it's still in the phase 1 portion. So we're looking forward to seeing results presented on the Takeda 788 molecule. So this looks like a very similar graph with Poziotinib, using the same kind of model cell lines, but there's one big difference. So they've used a couple of different comparator drugs, and it looks like their selectivity is a bit better. So again, they've grouped the EGFR exon 20 insertions on the right-hand side here. So you can see ASV, SVD, and NBG, and NPH. And it looks like they're well under this bar. My mouse is incredibly touchy. However, there's one thing that I will highlight here that I don't think that they benchmark this right. This is benchmarked against T790M, not wild-type EGFR. And again, wild-type EGFR is what sets toxicity. Most patients don't have T790M, or at least most patients with EGFR exon 20. So I don't think this is the correct benchmark. And I'm hoping that we'll see what that is. But what you really need to know is what's the white space here between wild type EGFR and these molecules, and we just don't know from this data. But you can see that Poziotinib is quite potent and that it takes a very low dose of this drug to inhibit EGFR exon 20 molecules. The question is that the same dose that also inhibits wild type EGFR, and that we'll have to see. So we do have some clinical data that's been presented on Poziotinib. It was presented at World Lung. This is the waterfall plot. You can see that they did have a number of responses. So they reported 8 responses out of 11 patients, or 73%. It's important to note that only 2 of the 8 were confirmed. So the FDA always looks. So there has to be a confirmatory scan at least a month later to show that this was an existing response, or that it was an ongoing response. And at least at the time that they presented this, only 2 of the 8 patients had a confirmed response. It's also notable that more than half the patients underwent dose reduction at the time that they presented, suggesting, not confirming, we'll have to wait for more data, that there could be some issues with inhibiting wild-type EGFR here. So that's what we know about Poziotinib thus far. What about EGFR monoclonal antibodies? Well, you'll remember from way back that the antibodies bind to the outside of the cell. That's not where the mutations are. So the antibodies, in theory, don't care about where they bind, what type of mutation you have, in theory, because they're binding a part of the molecule that's completely removed from where the mutation is. And so this has been a strategy that has actually been underexplored, and I'll just show you some anecdotal data from our group. Others have published anecdotal data, but to my knowledge, there's never been a focused trial of monoclonal antibodies in EGFR exon 20. Dr. Reese at UC Davis is now running a combination of, I believe, osimertinib and a monoclonal antibody, I think necitumumab. So might see if there's activity there. This is one of my patients that I treated many, many years ago. He was a 39-year-old never smoker with the EGFR mutation you see below. He came to us having had 3 prior lines of therapy, and we decided, again, this was a long time ago, we didn't have good drug options. We treated him with a combination of chemotherapy, which was carboplatin, gemcitabine, and cetuximab, and he had a fantastic response. You can see all these tumors in the right, and this tumor that was basically taking up his entire left lung just melted away after 2 cycles. Again, you can see this is all tumor when you look at this PET scan here. And this had an ongoing response. We only gave about 6 cycles of carbogem, but we continued the cetuximab. And this lasted for 13 months. Of course, the problem is we don't know if this was the chemotherapy or the cetuximab or a combination. It's only one patient, so it's really hard to know. This is another patient. This was actually presented at World Lung a couple of years ago by actually one of Dr. Eisner's fellows in pathology. This is a 71-year-old never smoker, different EGFR exon 20 mutation, and got a different regimen. This one we treated with Afatinib and cetuximab, and also had a fantastic response, lasted about 10 months. But Afatinib and cetuximab have a pretty high toxicity rate with a lot of really severe rash, because both drugs can cause rash. And again, we don't know if this was the Afatinib, the cetuximab, or the combination. It's only one patient. It's really hard to know. So I think there is something to EGFR monoclonal antibodies, but to my knowledge, there's not many trials really exploring this in this particular patient population. So to summarize this part, there are ongoing or planned studies of selected EGFRs, TKIs. There's anecdotal evidence of EGFR monoclonal antibodies, but it's really unclear on what the best combination strategy is. Do we combine it with chemo, with Afatinib, with other EGFR inhibitors? Do we give it alone? We just don't know, and that really hasn't been explored. So I will finish up the talk. I know we're running towards the end here. I'm going to finish up the talk with a novel strategy, one way that we think gets around all the problems that I've just highlighted, and that's tarlozotinib. So again, this kind of highlights the problem. What we need to do here is inhibit the tumor, but we need to avoid toxicity in the skin and gut. Those are the main wild-type EGFR. So the question is, the answer to this problem is clearly just deliver the drug only to the tumor. Seems easy, but how do we do that? We can't directly inject drugs into the tumor. There's often too many to do that, or they're inaccessible. So how do we get drug to the tumor, but not to these other areas? And so colleagues of mine at University of Auckland designed this fantastic drug. It's basically an EGFR TKI. It's actually structurally pretty similar if you look at this kind of compare it to Afatinib. It's structurally pretty comparable to Afatinib, but it's got this blue molecule on it, which basically makes this inert. Under hypoxic conditions, meaning when there's not oxygen there, this can undergo 1 electron reduction. This becomes then very unstable and fragments, leaving just the tarlozotinib TKI, or what used to be called T4000. So basically, this molecule that makes it inert drops off. That can then bind into that nice EGFR binding cleft that we talked about. It binds covalently. Again, it's similar to Afatinib. And this causes irreversible EGFR inhibition. And so the key here is that this only occurs under low oxygen conditions, and there aren't many areas in the body besides the lung, or besides tumors, that have low oxygen conditions. So this is a nice schematic that Rain Therapeutics has made to try and make this a little bit more digestible. So here's the Tarlox molecule, or tarlozotinib molecule. This is got both the EGFR TKI and this kind of blocking molecule. This is under this gets into the tumor. And you can see it reaching the tumor, but this molecule, again, won't inhibit any normal tissues until it gets, or any EGFR molecules until it gets fragmented. Under oxygen conditions, this embeds in the membrane, but oxygen sops up all the electrons, and so it can't undergo fragmentation. So in the skin and in the gut, actually, the gut can be hypoxic, but this drug is given intravenously. So the way it accesses the tissue, it's probably not under high or low oxygen conditions. Basically, oxygen sops up all these electrons, and the molecule stays inert. That's under oxic conditions. Under hypoxic conditions, you can see now the oxygen molecules are gone. You have these electrons generated by this reductase. This now fragments. The molecule is free to disperse into the cell and block EGFR. And then most importantly, this hypoxia doesn't have to exist everywhere. When you look at tumors, you actually see regions of hypoxia and regions of normal oxygen. But once this molecule starts getting freed up, it can actually diffuse across the tumor. So if there's a hypoxic region in one area, the drug, once it gets activated, can actually diffuse to other areas of the tumor and inhibit it. And this is how we think we're going to generate a therapeutic window when it's otherwise difficult to do so based on the similarities between EGFR exon 20 and wild-type EGFR. This is just an example of a PET scan using a molecule called EGFR. This is a hypoxia probe, so it tends to reside in low oxygen conditions, and you can see that this is residing by this colored annotation in the tumor. And this is a normal PET scan here with glucose, which is what we normally use. So you can see that lung cancers can be hypoxic. There was a small study published recently of 15 patients, and they looked at not just the primary lung lesions, but all the lesions in these patients, and saw that the majority, 18 out of 25 lesions, had significant hypoxia using this, this PET marker called HX4. So we do believe that lung cancers tend to be hypoxic and that we can generate the active molecule inside the tumor in these hypoxic regions. So this drug is not, it's not the first time that we're planning to study this in lung cancer patients. It was actually previously licensed by a company called Threshold. They called it TH4000 for Threshold. They used it at 150 milligrams per meter squared IV once weekly. That was based on phase 1 data showing that at higher doses it could prolong QT, which in theory, although we don't know the real risk, can cause cardiac arrhythmias. In theory, all TKIs can do this, so that's why if you go on a study of most small molecules, they do lots of EKGs on you because all molecules can, in theory, cause QT prolongation. But we think that they studied this in absolutely the wrong group of patients. So they studied it in patients who had an EGFR sensitizing mutation, so that means L858R exon 19, but they had to be resistant to a standard EGFR TKI and not have T790M. So they had to be T790M negative. So they looked at patients who were basically resistant to standard EGFR and probably didn't have a tumor that was any longer dependent on EGFR signaling. In fact, we know this from many studies. Here's one study of 155 patients. The majority had T790M, but the other patients all had other resistance mechanisms. And those other resistance mechanisms would not be expected to respond to an EGFR TKI. If they have MET or small cell or other resistance mechanisms, you wouldn't expect an EGFR TKI to work. And they didn't actually see much activity in those tumors, and I would have predicted that. Now, some people would argue that there are some patients with EGFR resistance that have HER2 amplification. However, it was actually a small number of patients. So they say 8% here, and you look at this number of 155, and you say, oh, well, what about those patients? They might respond because tarlozotinib should also inhibit HER2. The problem is they actually only looked at 24 patients out of this 155 with HER2 FISH, and they didn't compare it to pretreatment tissues. So they don't know that the HER2 amplification that they were seeing was actually a mechanism of resistance. It might have been there at baseline. In fact, Dr. Eisner can tell you we had a patient recently that I had gotten excited because I thought she had HER2 amplification, that we might be able to drug that, but when we look back at her pre-therapy sample, it was exactly the same level of amplification, and she had responded to the drug. So HER2 amplification, if you don't test both the pre- and post-treatment samples, is really a bit of a I don't want to say meaningless, but it doesn't prove that there was that mechanism of resistance. So we think that the patients that they studied in this trial were the wrong patients. They were selecting patients who no longer had an EGFR-driven tumor. They were studying something else. So how do we go about doing this? So my lab many years ago realized that there weren't models, good models. So all the data that I just showed you is in BAF3 models. You basically clone an EGFR molecule and you put it in a mouse B cell, which is not a lung cancer cell. It's actually an immune cell, and then test it. We thought it would be helpful to actually derive cancer cell lines from patients. So we did that. CUTO 14, 17, and 18 all have an EGFR exon 20. As I mentioned before, they have the three most common mutations, the duplication of ASV, NPH, and SVD. They're all from different patients and all therefore have different characteristics. And we thought these would be useful in studying EGFR exon 20. I just wanted to make the point that we're not selfish. We actually have collaborated with a number of groups. There's a group in Germany that is looking at EGFR exon 20 inhibitors. We've shared them with the Cancer Institute in New Jersey, the Broad Institute, Ariad, UC Davis, MD Anderson, New Zealand, and others. So we make these reagents available to other groups who are interested in trying to design better strategies to inhibit these. Okay, so I mentioned EGFR dependent. Some people might question, well, you know, these cells have an EGFR mutation, but are they dependent? Here we've taken away EGFR. It's called a knockdown technology. So we take the protein and we remove it genetically or decrease it. You can see that we decrease the band here in each of these three cell lines. And when we look at how the cells grow, to varying degrees, this blocks their growth. So if you genetically or take away the protein from these cells, they no longer grow. That shows that they are truly EGFR dependent cell lines. Now, getting to the drug strategy, we show that the active moiety, so this is experiments that are done under normal oxygen conditions. So here we're using just the active compound, the Tarlox TKI, and we show that at very low doses we can inhibit EGFR. So this is the phosphorylated EGFR that goes away. When we do that, it also inhibits downstream signaling of critical pathways that I mentioned very early in the talk, AKT and ERK. Again, showing that these cell lines use this as an EGFR dependence. And then it's very similar actually to Afatinib. I mentioned that it was structurally, the active part of the molecule was very similar to Afatinib, and you can see that here. It's actually slightly better, but not a lot better, and much, much better than Gefitinib. That's one of the cells. No. Somebody have a question? And so, and the other two cell lines show a very similar profile, that you inhibit EGFR and downstream signaling at a dose similar to Afatinib and much better than you do with Gefitinib. So this is CUTO 17 and 18. So we know that the active compound is able to inhibit these cells. So this, or at least inhibit EGFR. Now when we look at cell proliferation, so the faster these curves drop, with each of these drugs, the better inhibitor they are. So again, here we're doing this under normal oxygen conditions. So we're using the blue Tarlox active compound, you can see is slightly better than Afatinib in each of these molecules, much better than Gefitinib in yellow, and also much better than Tarlox. So Tarlox is the prodrug. So when you put the prodrug under normal oxygen conditions, as we predicted, it's very ineffective. It's very bad at inhibiting the cells, which also means it's going to be very bad at inhibiting wild-type EGFR. And again, this shows that if you don't convert the drug, you're not going to, in the periphery, in the blood system, in the skin, and in the gut, you're not likely to get toxicity because this drug is very poor at inhibiting EGFR molecules, but the active compound is. And this generates about a 30 to 50-fold shift between the prodrug and the active compound under normoxic conditions. But of course, what we really want to know is this, if you give the prodrug, right, which will be non-toxic to normal tissues and hopefully kill the cancer cells, if you give that in a living animal system, can it shrink tumors? And so we've so far done this with one of the models that grows in mice. So we inject these cancer cells into mice and look for tumor inhibition. And so we tried a bunch of different strategies here. Blue is no treatment at all, so basically like placebo. Yellow is Afatinib. That also looks ineffective, as we would have predicted based on the patient data, right? We already know Afatinib is very, very bad at inhibiting EGFR exon 20, and this looks almost identical to nothing alone. I mentioned anecdotal data with cetuximab, so we were exploring that here. Cetuximab alone actually caused some stabilization of the tumor. It didn't cause regression, but it caused them to stay the same. Cetuximab plus Afatinib in this model looked identical to cetuximab alone. So to me, that suggests that if you're doing cetuximab plus Afatinib, you're getting a lot of extra toxicity without an extra benefit. But again, this is a mouse model, not a patient. So again, cetuximab was really driving this. Afatinib didn't do anything. And if we give the prodrug here, tarlozotinib, we cause tumor regression. So again, this is the prodrug. This is the drug that is very ineffective under normal oxygen conditions. But when we inject it into mice, it actually causes tumor regression, suggesting that it is getting activated at the tumor site and causing tumor regression. And so this was kind of the key experiment that really told us we should move this forward into patients. And so that leaves us with our clinical strategy, our clinical trial strategy design that we're developing at Rain Therapeutics. The number of patients you see is small. That's actually based on what drug we have existing. We're currently fundraising to so that we can make more drug. But the idea here would be EGFR exon 20 or other ERB-driven cancers. We probably explore the existing 150 milligrams once weekly dose. We might slow down the infusion. It was previously given over an hour. We think that slowing the infusion might cause less of that QT issues that we talked about. We're obviously going to follow that with both EKGs and cardiac Holter monitoring. And again, this is designed for EGFR exon 20 insertions or other patients who have poorly responsive tumors to EGFR inhibitors. We are going to, in the initial study, exclude prior EGFR TKIs because we want a clean population of patients. We plan to do PET imaging for hypoxia to see if that correlates with response. And the STEAP4 quantification, that's actually the reductase that's been identified, and we think that this is highly expressed in lung cancer, but we'd like to check that. So it's a very straightforward design. The idea here is that we would see enough responses in patients to kind of move it forward to a much larger trial. With that, I'm going to end and take questions. I want to give a huge thanks to my collaborators, Adam Patterson and Jeff Smale at University of Auckland, who designed and did the initial work on the drug. Developmental Therapeutics program at our cancer center here gave us a pilot grant to study this. The cell lines were developed under our lung cancer SPORE grant. My lab has done a ton of work on, derived all of our cell lines, so he attends all of our biopsies and grows all of these cell lines. Adriana Estrada Bernal did a lot of the work that I just showed you in vitro and in mice. We've got a bunch of other lab members that are helping out with this. We've gotten donations from the Hanlon Foundation, from a local donor here, the Burge Endowment. Rain obviously is developing this compound now and fundraising to move this into clinical trials. And of course, I'd like to give a huge thanks to patients and their families, both who've enrolled on various clinical trials and of course who were gracious enough to donate their samples for us to generate these cell lines and hopefully develop new strategies to treat this cancer. With that, I will end, and sorry I've gone a little bit over, but I'm happy to take questions from the group.
Dr. Doebele, Bob Hamlin here. Hey, thank you very much for that fascinating technology with the Tarlox. It's amazing what the doors that opens. So thank you for sharing those data with us, all in the context of the other data that you shared. Very nice map that you provided us. There are a couple of, we got some questions to share with you that have come in from the group, and I'll just go through these if that's okay. A general question to begin with, one of the things that this is more broad, one of the questions that we've been wrestling with was how many exon 20 insertion patients are there actually in the United States or even the world for that matter? I mean, we've been trying to estimate that. We don't know if you've taken a crack at that or not. We're wondering.
Yeah, so we did look at those numbers. So our estimate is about 2,000 patients per year in the US for EGFR exon 20 and probably about twice that many for HER2 either amplified or mutant tumors. So, you know, in our estimate, there's about 6,000 exon 20 patients in the US per year.
Got it. Okay. Thanks for that. One of the things, you know, our group, I would say a fair number of folks in our group are already on the Poziotinib trial, Dr. Doebele down at MD Anderson and now at some other satellite sites.
Yep.
And I know that in looking at the Tarlox, you know, you have an exclusion criteria, you know, no prior TKI, but let's ignore that for the time being. And just in theory, if, you know, at some point TKIs run their course, right, and people develop resistance, and then they start looking for the next therapy. Does it make sense that somebody on something like either Poziotinib or even the 788 would find that the Tarlox, if it does indeed show that it's working, would that sequence make sense, or would these technologies, regardless of whether it's Tarlox or Pozio or 788, does it run its course and then you got to move away from a targeted therapy onto something else? Just wondering if in the longer term game here, the Tarlox, if it were available for us, if that might be useful for us.
Yeah, so it's a fantastic question. It's a little bit complicated. So first let me say, you know, one thing is if you're on TAK-788 or Poziotinib and it never works, and you know, there's a significant proportion of patients where it doesn't cause a response, you know, then those tumors still might not have just, you know, you didn't achieve the dose, so you never inhibited the tumor. Those patients may not necessarily be resistant to any EGFR inhibitors, and it might make sense to explore that, right? So in the same way that patients who have a standard EGFR mutation, such as L858R, get T790M, those patients, based on that resistance mutation, can then go on to another EGFR inhibitor that's specific for that mutation. So that gets to the next part. So if they respond initially to Poziotinib and or TAK-788, then it depends on what the resistance mechanism is, right? So if they all develop MET gene amplification, an EGFR inhibitor is not likely to work there. However, if they develop, you know, perhaps HER2 amplification as a mechanism of resistance, or some mutation that tarlozotinib hits in EGFR, then yes, that might work. But that's going to take, you know, time to understand. You know, if you look then at the patients who are responding to Poziotinib or TAK-788, how do they become resistant? And we don't have a good sense of that. It might be through it could be through T790M. It could be through C797S. That's actually, C797S is the binding site for all these covalent inhibitors. And if that's the case, you know, Tarlox may or may not work in those patients. So it's a long way of saying it kind of depends on how they become resistant. And, you know, it'll take us some time to accumulate those resistant tumor samples. So I would encourage patients, you know, who are on TAK-788 or Poziotinib, if they have a response for, you know, 3 or 6 or 10 months, you know, and then become resistant, you know, donating resistant samples to help us understand how patients become resistant to these will then help us come up with the next therapy.
Got it. Okay. Got it. Thanks for that. Got another question that came in. The hypoxia mechanism with the Tarlox, you know, it's fascinating how that works. Would that be applicable to any of the other drugs that are currently being looked at, like Afatinib? Could you put a similar mechanism on any of the other TKIs, or is it a unique combination?
No, in theory, this platform could be used to develop other ones. And in reality, this drug is very similar to Afatinib when you look at the structure. So the active molecule. So yes, in theory, you could do this for other difficult to drug targets. Now, for patients who have like ALK, one of the reasons we can drug, ALK or ROS1 so readily is that ALK and ROS1 aren't expressed in a lot of normal tissue. So there's not a lot of side effects you get from, even, giving massive doses of these drugs, because the protein doesn't have much of a role in adult human cells. And so, there may not be as much of a need to do that in certain drivers, but, there may be others that have been difficult to drug. We've had a hard time drugging RET, for example. And so this might be applicable to RET. But yes, in theory, you could attach a number of different molecules using this hypoxia sensor and achieve higher doses in regions of hypoxia.
Okay, great. Thank you for that. And one final question here, Dr. Doebele. And this is, you're sitting at the center of much activity. We're diving deep into the activity of the Tarlox, but you also see a very broad landscape and are very conversant with that. Many people on the phone are probably interested, beyond the targeted therapies, what do you see as the next step for anybody who has progressed on the targeted therapies? Where do you think those next steps would be? You touched on some of them perhaps in your talk, but I know that you see more than that. Could you just comment briefly on that?
Yeah, again, as long as the tumors stay dependent on EGFR, there are strategies to design different drugs to kind of fit into that molecule and inhibit it. We could also consider adding in things like cetuximab, which don't care about mutations in theory, although they're still limited by some toxicity. And again, it really depends on the resistance mechanisms. It's been a huge focus of my lab. The problem that we've encountered with acquired drug resistance, meaning you initially respond and then you become resistant, is that some patients have a druggable mechanism of resistance where you can just give a new drug that kind of works around that particular resistance mutation. But a lot of patients develop alternate signaling pathways that require multiple different drugs, and that's we've done a lot of preclinical work to show how that happens in a variety of different models. And a lot of what we learned from ALK and ROS and standard EGFR mutations are likely to apply to EGFR Exon 20. But we've hit a bit of a roadblock in terms of coming up with good clinical trials where we can actively combine, drug A and drug B. For example, an EGFR inhibitor and a MET inhibitor, although those trials now are going. So my hope is that, we'll define the spectrum of resistance mutations and be able to smartly apply those once, one of these drugs fails. Got it. Okay. Yeah, wow, such a good conversation. We could go on for a long time, but I want to honor, the time contract we have with you, Dr. Doebele, and also the folks who have phoned in. I'm sure there will be other questions coming in to Marcia or myself afterwards, and we might send some of those your way if that's okay. Great. Happy to help. And I think Marcia's trying to distribute this video too. It's going to be quite a big file. So. Understood. Well, thank you so much for making time out of your own busy schedule. You're juggling a lot there. You're up to some really great stuff. We truly appreciate your taking some time to share what's going on with you and your group there in Colorado. A lot of folks have phoned in tonight, and I'm sure speaking on behalf of everybody, thank you very much, Dr. Doebele. All right. Well, it's been a pleasure, and I hope that we'll be bringing some good news in the coming year. Oh, thanks. And to everybody who phoned in, thank you very much. We'll close at this point and look forward to our next telecon whenever Marcia schedules that for us. So thank you, everybody, and good night. Thank you.